morning students. Today I am going to discuss on topic diabetes insipidus, which is nothing but because of ADH insufficiency. That is, whenever there is antidiuretic hormone deficient or loss of antidiuretic hormone, that results in a condition called diabetes insipidus. And we all know what are the functions of, as the name suggests, antidiuretic hormone. Diuresis is excess loss of water in the urine. So antidiuretic hormone means increased water absorption. So the function of ADH, which is secreted from posterior pituitary, is water will be reabsorbed. When the excess water is lost in the urine, that will be reabsorbed. That is the function of ADH. Diabetes insipidus is ADH is decreased. So what is expected? Yeah, increased water or increased loss of water in urine or more water loss in urine. And I hope you know what is the term. Yes, correct. Polyuria. So polyuria is one of the symptoms in diabetes insipidus. That is, they will tell excess urine. They keep on going more urine 4 times, 6 times, 8 times like that. So polyuria, the reason I told, antidiuretic hormone. So what happens? When the antidiuretic hormone is not functioning, more diuresis. So more loss of water in the urine, as I mentioned. So polyuria. Then imagine, when water is lost more in the urine, what happens? What will happen to your body? It will have more water or less water? Obviously less water. So to compensate that, because of polyuria, there is decreased water. So whenever there is decreased water, thirst will be there. Human mechanism, homeostasis. So note it down, this thirst is called as polydipsia. So in diabetes insipidus, the two main symptoms are polyuria, polydipsia. ADH is secreted from posterior pituitary and control is from hypothalamus. So polyuria, polydipsia, increased thirst. Why increased thirst? Water is lost. My body is deprived, my body is dehydrated. So my body wants to compensate that. So what I do? I keep on drinking water, and whatever water I drink keeps on lost because ADH is not functioning. I am able to understand. Now you can ask, sir, polyuria, polydipsia also occurs in diabetes mellitus. So now I will come to the difference between diabetes mellitus. Now listen here, the difference between diabetes mellitus and diabetes insipidus. In case polyuria, polydipsia, note it down. In diabetes mellitus, 3 types, that is polyuria, polydipsia, polyphagia, excessive eating also will be there. And one more point in diabetes mellitus is there is increased blood glucose. Whereas in diabetes insipidus, normal blood glucose. Please note it down. So now from this video you should know that if anyone is complaining of polyuria, polydipsia, don't come to an immediate diagnosis of diabetes mellitus. You have to check blood glucose level or blood sugar level. If the blood sugar level is increased, we can suggest that it is diabetes mellitus. If your blood glucose is normal and you are having only polydipsia, polyuria, it is very highly suggested of diabetes insipidus. If blood glucose is normal and you are having increased thirst, increased urination, and the eating is not affected much, no polyphagia, that means it is mostly diabetes insipidus, ADH decrease. Now there are 2 types of diabetes insipidus, central or neurogenic, nephrogenic. As name suggests, what I told, from hypothalamus there is a control to the posterior pituitary, and posterior pituitary is the one which is concerned with ADH or hypothalamus. If there is any problem with hypothalamus or posterior pituitary, that is called central diabetes insipidus. So in this case, ADH is very less or no ADH. Causes, for example, head trauma. So any head injury, pituitary could have been affected, or pituitary adenoma, encephalitis. So central brain, that is either posterior pituitary or hypothalamus. So in a case of any head injury, head trauma, pituitary adenoma, encephalitis, craniopharyngioma, so all these are conditions which could cause posterior pituitary hypothalamus lesion. Then what will happen? ADH is not there. If ADH is not there, diabetes insipidus. But all these are concerned with center. So it is central diabetes insipidus. Now coming to nephrogenic, ADH is normal, but it is not functioning. So receptors problem. Receptors decrease. ADH not able to act. Some resistance. For this, I will generally tell sickle cell anemia is considered to be one of the causes, rare causes. Lithium, one drug like lithium, demiclocycline. So all these sickle cell anemia, lithium, demiclocycline, infiltration, all these are concerned with kidney level. So ADH is coming from posterior pituitary, from hypothalamus, normal, but it is not able to act on the target, which is the kidney. This is called nephrogenic, kidney level. So first I told about diabetes insipidus, and I clearly told how to differentiate diabetes mellitus and diabetes insipidus. Now in this slide I am discussing about central diabetes insipidus or neurogenic diabetes insipidus and nephrogenic diabetes insipidus. Yeah, now one more doubt. I have told what is central, what is nephrogenic. Yeah, now how to find out whether he is suffering from central diabetes insipidus or nephrogenic diabetes insipidus. Yeah, that comes, please note it down. Now we are entering into important water deprivation test. Note it down, very important test to find out whether it is central or nephrogenic. In water deprivation, what it make? 2 hours, no water intake. So what is expected? 2 hours, no water intake. So when there is no water intake, what will happen? Normally, normal ADH will increase. So water deprivation is I am deprived of water. 2 hours I will not give the patient any water. So my body is more of water, less of water. And we all know the function of ADH, antidiuretic hormone, increase water reabsorption. So ADH concentration will increase or osmolarity will be greater than 600. So when I do water deprivation test to a patient suspected of diabetes insipidus, after no intake of water for 2 hours, I will check. If it is more than 600 minutes, that is normal. So that is no diabetes insipidus. Maybe he is wanted drinking too much water or increased water intake. So he is not diabetes insipidus. Now next, for the same patient, water deprivation test, 2 hours is not taking any water, and I am checking ADH. What is expected when there is no water? ADH should reabsorb the water because I want water. Your total body water is 60%. You require water. But if ADH is not increased, in fact decreased, or osmolarity is less than 600 osmolarity, so that is diabetes insipidus. So the test which I prove that he is having diabetes insipidus is water deprivation test. 2 hours, don't give him any water, check his ADH. ADH is not going to function. If ADH is not functioning, urine osmolarity will not increase. See here, urine osmolarity is less than 600 means dilute. Dilute urine, very simple. Very simple. When you are not taking water, what is expected? The urine will be, I am asking you, pass the urine answer. I am not taking any water for 2 hours. My urine will be concentrated or dilute. It is expected to be concentrated. But if you are having diabetes insipidus, what happens? ADH is not functioning, your water is not reabsorbed. So what will happen to urine? Urine is dilute. So even though there is no water, whatever is there, it is being kept excreted in the urine because ADH is not functioning. Yes. Because of water deprivation test, I am finding out he is having diabetes insipidus. Again question, whether it is central diabetes insipidus or nephrogenic diabetes insipidus. desmopressin. So now to know whether ADH is not at all coming or ADH is coming but kidney is not functioning, I do desmopressin. The desmopressin is nothing but ADH analog, or I am giving ADH from outside in the form of analog. It is a form of ADH, desmopressin. Now what is expected? Now you answer yourself. I will write here central nephrogenic. What is the problem? ADH is not there. Nephrogenic, ADH is normal. Now tell me, in central diabetes insipidus, ADH is less. Now what I am doing? I am giving ADH. So what is expected? Yes, urine osmolarity increases. ADH is going to work because I am giving ADH. See here, I am giving ADH analog desmopressin. What is the problem? ADH is not there, but I am replacing the ADH with the form of desmopressin. So normal. Urine osmolarity comes back to normal, or urine excretion is decreased. Decreased urine excretion if it is central diabetes insipidus. Now coming to nephrogenic diabetes insipidus, already is having normal ADH. The problem is in kidney, either ADH receptors, all those things. I told the causes also, like lithium, some drugs, some infiltration, all those things. In this, what happens? Even if I give ADH analog, no use. Still increased urine excretion, or even if I give desmopressin, there is excess water excretion in urine, osmolarity is decreased. That means ADH, even if I give ADH, no use. That means it is nephrogenic diabetes insipidus. If I give ADH in the form of desmopressin, ADH analog, if it works, then means I have to suspect central diabetes insipidus. So now we are entering into final part. Treatment of diabetes insipidus, almost the answer we know. In case if he is suffering from central diabetes insipidus, treatment is ADH or desmopressin, which is analog of ADH. If he is suffering from nephrogenic, no use in giving ADH. In previous slide we saw. So what should I do? Here actually we will be giving diuretics. Don't confuse. Don't think diabetes insipidus already is passing more urine. Please listen. Diuretics is one of the drug which causes increased urine output. Already nephrogenic diabetes insipidus there is increased urine output. But what happens when I give diuretics? There is loss of sodium from PCT. Please note it down. There is loss of electrolytes from proximal convoluted tubule which causes increased loss in urine. But because of loss of sodium, what happens? Your body tries to reabsorb sodium because sodium is lost. So homeostatic mechanism. I am giving diuretics and making sodium loose. I am giving diuretics and make sodium loss in the urine. So what your body tries to do? Because of this, tries to reabsorb sodium. As sodium is reabsorbed, water is also reabsorbed. So when water is reabsorbed, urine osmolarity increases. So water is reabsorbed. But what happens in diabetes insipidus? Water is lost. But because of giving diuretics, what happens? Water is reabsorbed. So if he is suffering from central diabetes insipidus, give ADH. That is desmopressin, analog of ADH. If he is suffering from nephrogenic diabetes insipidus, give diuretics. So I hope it is very clear. Today I have discussed in detail about diabetes insipidus, types of diabetes insipidus, symptoms, test investigation, how to find out whether it is central or nephrogenic diabetes insipidus, and the final slide, treatment of diabetes insipidus. I hope this video is very clear on diabetes insipidus. If you are not subscribed to our channel, Dr. Sen Physiology, please subscribe to our channel and continue to support us. We will try to put as much physiology videos as possible, both theory as well as practicals. We will meet in next video. Thank you.